You're juggling it all: work, family, decisions, expectations. Six hats, maybe more every single day. But behind the scenes, your body is running on stress, and stress left unchecked will lead to illness. I'm Dr. Shami, an integrated family doctor, and this is Six Hats, the podcast that helps you understand what stress is doing to your body and what you can do about it now. Hello, everyone. Welcome back to the Six Hats podcast. And today I'm really excited to have Dr. Sami Timimi, a UK-based consultant child psychiatrist, an author, and outspoken critic of how modern psychiatry labels children. We're going to explore conditions like anxiety and depression and ADHD, which are now affecting more children than ever before in history. But more importantly, the dangers of pathologizing normal emotional responses, and how sleep disruption, screen time, and even family dynamics are often overlooked. So welcome, Dr. Sami.
Thank you very much. Thank you for inviting me.
So I'd love to begin by hearing about your journey into child psychiatry, but what led you to start questioning the current system?
Yeah, there's lots of different ways that story can be put together. It depends on your starting point, because one of the things that I grew up with, because I grew up in Iraq in my adolescence and then moved to Britain. So due to deteriorating political situation, but in my time in Iraq, I was surrounded by family who were quite religious in their outlook, but my parents were not. And I had all those kind of meaning of life conversations, and I was aware that there were different ways of looking at and understanding the world. And then when I came to Britain, I had a bit of a culture shock because the way the schools were organized and how teaching was very different. So I think in my early life, before I went into medicine and before I became a psychiatrist, I'd already been exposed to the idea there are different ways of looking at the world and to question any particular truth claims. So I think I carried that into my training. I got interested in psychiatry because I found myself during my medical training more interested in sitting, talking to patients. When we used to go and have to talk to patients, I found that the patients wanted to talk about what was going on in their life and their relationships and, what happened and how it happened and how they felt. And I found myself more interested in that aspect of healthcare and the impact it has on people, psychosocially. And I found that was often the thing that people were wanting to talk about, the impact of the kidney function test rather than the kidney function test itself, if you see what I mean. So that drew me into psychiatry. I was interested in the early years in psychiatry in cross-cultural psychiatry because of my background, and felt that there was something in psychiatry that wasn't really acknowledging the different ways people might view and understand the meaning of things going on in their life and their experiences. And when I had my first placement in child psychiatry, which was in 1992, there was something about the approach that really made sense to me. So the thing I learned, so in many ways, I consider myself a traditional child psychiatrist because in that department, we weren't diagnosing people. We're just talking about the problems. We even used the phrase an identified patient. So the idea that this is at least initial reason why somebody has come to seek some help. But that doesn't mean that the location of the problem is within the person who is being identified. So we call it the identified patient because in those days, the way of looking at, there were two important things that I think I learned early on from that way of looking at child psychiatry. The first was the importance of context. So a systemic approach was the dominant way in those days. And by systemic, it just means that you take into account all the things around the child rather than just what's going on in between the ears. Yeah. And it kind of makes sense because most of the important decisions for children are not made by them, but various people in different caring relationships to them. They go to schools, they have peer relationships. And it kind of made sense to me in general, not just in child psychiatry, but I felt this was something that was, if you like, a gift to the rest of medicine from child psychiatry. And the second one was the concept of development. And this is just broadly the idea that things change over time. And of course, as we grow up, that's the one predictable thing. You're going to change. Your body's going to change. Your interests are going to change. The way you view the world is going to change. Your existential way of understanding meaning and so on is going to develop. And so just the idea that life is always in motion and not to get caught up with a static idea of problem and a static idea of what is going on and how to solve it. So that was then what drew me into child psychiatry. And of course, it's been a bit disappointing to see that child psychiatry has sort of gone down that road of medicalization. The thing that really got me into the kind of academic bit of questioning was during my training. This was now about 1995. I was with a consultant supervisor. We were in East London. It was a placement in East London, a high density of ethnic minority children, particularly those of Afro-Caribbean background. And there was a high prevalence of children from those backgrounds being labeled as having behavior problems, higher rates of exclusion from school. And the concept of ADHD was just beginning to filter into the UK. And the consultant wanted to do a bit of research to see if this might be partly explained by a higher prevalence of ADHD. So I agreed to go off and do a literature review. And you know the concept of will-o'-the-wisp?
No.
So the will-o'-the-wisp is in the mist. You see something and you think it's there, but every time you go to grab it, there's nothing there. And you keep... So this idea that there's something there, but actually you can't ever grab it. So that was my experience doing the literature review. All these papers, all these reviews, some books, articles. It seemed to me very strange that there was a concept and it was based on certain types of behavior that most kids will show at some point. You know, we're not talking about qualitatively different behaviors to what you'd expect. And there was an assumption that these behaviors represent a discrete characteristic condition. So it just felt to me like I was encountering the early stages of a concept and realized this concept had no foundations. It was somebody had said, this is the concept, and we'll use that as the basis for all sorts of research. But the concept itself seemed to me empty.
Wow.
Empty of anything concrete. So that experience of doing that literature review at the start of the development of a concept that has now become so widely known was a really, that gave me my academic instruction to start really questioning all sorts of other constructs.
You're absolutely right, because I've always sort of questioned, I mean, we are going to go into ADHD, but I've always questioned how quick we are to label a condition, and especially in a child. And it's really interesting when I reflect on psychiatry. What really happens is the GP is almost frontline in terms of diagnosis, but we've not really had psychiatric training. I did 6 months of training in psychiatry, but that's just not enough. And you're absolutely right. It's so subjective when it comes to diagnosing.
Yeah.
Incredibly subjective, to the point of scary, how you can go to a GP and say, yes, you've got generalized anxiety disorder, you've got depression. When in actual fact, you've just lost a family member, you've lost a job, you've actually going through life changes. And you will not believe, Dr. Sami, how often I hear the story of maybe friends or family going to see a GP and saying, yeah, I was offered an antidepressant, but I'm going through actually a tough time. I'm going through a divorce and offered an antidepressant.
Why wouldn't you be depressed?
Exactly. And how quick are we to judge? And unfortunately, it is the GP, it's the front line that is quick to prescribe and quick to diagnose. And quickly it's on their medical records, depression, anxiety, the start of medication. And I loved how you said concept. I would love to explore the diagnosis. How do we come about to a diagnosis? Because I do want to just quickly talk about the DSM, the Diagnostic Statistical Manual of Mental Disorders. And just for my listeners to know that 7 editions, 160 to 170 mental health conditions, And believe it or not, what surprised me the most, guess what? Homosexuality was considered a mental health condition until 1973. And it
And
just,
it was only narrowly voted out. That's how it changed. It was a vote. It's not a scientific thing. They had a vote in 1973,
wow.
and there was a narrow majority. I think it was like 55% voted for it to be taken out. And it was after a campaign from, a developing rights group who were campaigning to
Wow.
have it removed. So it's good to appreciate that the whole development of DSM and the changes that have happened in DSM over time are political in nature. They are not scientific. They are not to do with scientific discoveries.
Wow. And I think it's really important for listeners to know, because when you go and see a doctor, where do they get the guidance, make that diagnosis? And unfortunately, in today's world, it's very quick to make that diagnosis. And we're going to go into ADHD, but even going back to how quick doctors like to prescribe antidepressants for kids. And I just looked at the data for Australia, and it's the Pharmaceutical Benefits Scheme, shows that antidepressant prescriptions for children under the age of 18 rose by 165% from 2013 to 2023, reaching a rate of 196 prescriptions per thousand individuals. But what's really scary is, as a GP and an integrated GP, when I hear children go to see a pediatrician for an opinion, it's very quick to go, you're anxious, let's prescribe an antidepressant. And I know the long-term side effects. It's scary how there is no informed consent because of protracted withdrawal syndrome or even post-SSRI sexual dysfunction. And now I'm seeing, and I feel for them, my heart goes out to all these young adults trying to deprescribe, trying to come off these antidepressants over years.
Which is not easy.
Absolutely. So in terms of prescribing antidepressants, how did you get around it, Dr. Sami, as a child psychiatrist? What was your method in seeing children with emotional?
Well, as I say, I came from an approach, so I've been working a long time, where medication was hardly ever prescribed to children and young. So in that first placement I had in 1992, there was only 2 children, and the whole time I was there at that night. Yeah, that my first placement, only 2 kids in that department were ever prescribed medication. And both of those children, so I was there for 9 months, both of those had psychotic features in their presentation. And even with them, I remember meeting with them, like meeting with one of them for individual therapy, talking about the meaning of the things, meeting with him and his mother. So even then, the medication was just seen as an adjunct, something to help with the intensity of the experience, but it was still being viewed as a meaningful experience and something that should be engaged with beyond just medication. So even in those 2, as far as the whole thing of antidepressants, it's, excuse the pun, depressing that Australia became one of the places where it really increased, because in Australia you've had a group of really, really good critical psychiatrists. I know quite a few of them.
Oh, wow. Okay.
Including somebody called John Uridini. I don't know if you've come across John Uridini.
Yes, that's
Yeah,
right.
so he's written a lot about, and he was one of the early people to raise the flag of alarm about the emerging literature on antidepressants in young people, pointing out that it doubles the risk of people experiencing suicidal impulses. So you're treating somebody with a condition that actually might make the most extreme outcome even worse. This was acknowledged. The labels came out with cautioning, but sooner or later off it went again. And the same has happened in this country. So the idea went around, if we just monitor people closely when they first go on an antidepressant, then we can get them past that period and then they'll be okay. I'm not so sure about that, because the other thing that people like John Uridini, and I've looked at that and I've also published on this question myself, we're finding out is that they actually don't make any significant difference compared to a placebo. So they don't result in any medium to long-term improvement above a placebo. And that has actually been my clinical experience. So I've ended up prescribing sometimes because of pressure from the people who expect it, but also because I inherit people who've been prescribed by their GP or prescribed by another psychiatrist, particularly if I'm inheriting people who've had an inpatient stay at some time. And I can say, hand on heart, in all those years, and I've been an inpatient consultant, outpatient consultant, I've done, pretty much every branch of child psychiatry you can think of. I can say, hand on heart, I have yet to come across one young person who has been prescribed an SSRI and it resulted in a sustained long-term improvement.
Wow.
I have come across a number of young people who have had a period of maybe a few months, maybe sometimes longer, where they've experienced an improvement. Then they come back and say, it's not working as well as it used to work. Can you increase the dose? Or maybe I need to switch to another one. Or maybe you need to add another medication in. And unfortunately, by then, they've become convinced because they have what is, I think, now widely acknowledged an enhanced placebo effect, because it does have an effect on how you feel. And if you're interpreting that as the therapeutic thing, but of course, placebo effects wear off over time. So the unfortunate thing is once you've ended up down that route, you're now going to be potentially exposed to something long term because you've become convinced actually you need this, particularly if you try and stop. People are still being encouraged, oh, you can stop over 2 weeks or you can just discontinue suddenly. And when they try and stop, they feel worse. That also, they confuse withdrawal effects to the original condition and the idea that they need them. So I talk to my patients about that. I show them the last Cochrane review, which came to the conclusion that for all SSRIs, the effect size is small and non-significant. That's in the writings there.
Wow.
So I just show them those papers sometimes, and I talk to them about my experience, but I still have people who, despite that, because it's so widely prescribed now, still want to have a go with it. At least if I warn them about that, we can have a go, and most people then actually want to come off it.
Wow. I'm so glad you mentioned those side effects. And you're absolutely right. It's what the message I want to get across. It's so quick to start. It's easy to start, but it's so hard to come off. And you mentioned about the risk of suicide. And funnily enough, and I don't think people in Australia know, the TGA, which is the Therapeutics Guidelines Australia, which regulates medication, has not advocated that for less than 18. And your apps, SSRIs, and you're absolutely right. I remember chatting to a psychiatrist going, right, she's 17. Are you sure this is the right thing to do to start an SSRI because of the risk of suicide? He said, oh, that's fine. Absolutely fine. So you're absolutely right, Dr. Sami, because the narrative, even though the data is there, like the Cochrane review and the data is there, the messaging hasn't really got to all the positions of authority. So GPs and even psychiatrists and pediatricians are just quite blasé about the severity of the side effects. And I'm just going to mention two massive side effects is post-SSRI sexual dysfunction, which I learned about last year, and protracted withdrawal syndrome. And I'm seeing now patients in clinic, 18 years of an SSRI. It's going to take 5-6 years for them to come off it. And they having anxiety, panic, dizziness, brain sap. It's almost heartbreaking to watch.
Well, it is heartbreaking, isn't it? We're talking about kids. The one constant about that I talk to young people and parents about, the one constant is that you will change. That's what happens. So, just be patient.
Absolutely. And I really want to get the listeners to say, if you are on one, have a conversation with your doctor, because it's so easy in medical model is to, right, here's another script, the repeat script. It's so easy. I just need another script without a conversation around it and just really highlighting that. But Dr. Sami, I'd love to move on to ADHD. It's now one of my passions to really spread this information, because a number of patients that come to see me actually, more adults suddenly decide they've got ADHD. and from this criteria that they've read about. But what I really want to reach out is to all those children who, the parents think that the kids have got ADHD and are very quick to medicate. And I just want to get them to make a much more informed condition. So tell me more about how ADHD is actually diagnosed.
I think what might be useful is to make a segue into the whole what we mean by mental health, mental disorder, psychiatric condition, and what we mean by diagnosis. Because if we can unpack that, then it might help understand that question. I don't know if I should mention, I recently published this book, Searching for Normal. So I look at all of these assumptions in there and lead up to trying to understand what is this explosion of ADHD and also autism and neurodiversity. What's that all about? So the first thing to understand is that all definitions of mental health and behavioral difference are subjective. There is no empirical anchor. This is what I was saying earlier about that will-o'-the-wisp experience. When you try and grab hold of something concrete, there's nothing there. It's just a list of behaviors. To call them symptoms, you've already forced them into a framework of meaning. So you've already made a philosophical jump, if you like, in terms of the system of knowledge you're trying to apply to these behaviors. The issue with not having any empirical anchors is that your definitions, being subjective, can be expanded. They can be expanded horizontally, which means encompassing less severe presentation, and also encompassing other behaviors, which is what's happened with the shift to adult ADHD, is you encompass behaviors that are different to the ones that are meant to be existence for children. But you can also expand it vertically. In other words, originally, we had something called hyperkinetic syndrome, if you go back about 25, 30 years. It was considered to be very rare, like 0.1 to 0.5% of children, and it was considered developmental. By developmental, these were considered to be behaviors that most children will grow out of. So when you start to expand it vertically, you started to call it ADHD. First of all, you start to include more children. So ADHD was meant to be like 3 to 5%. So you're including, you've done the horizontal expansion, but you now start to say this is potentially lifelong. So you're now expanding it from just children up into adulthood. The whole idea of adult ADHD starts to come around, at least in the UK, around the mid to about 2004, 2005, beginning to talk about that. Up until then, it was considered to be a childhood condition. And the idea was most people, if they went on to stimulants, would be weaned off stimulants before they entered adulthood. It used to be the practice when stimulants first came in that children wouldn't take them over holidays, for example, or sometimes even weekends, because it was considered to be something that might help them, that can only work really in more structured environments like school. So the concept of drug holidays, so that also starts to disappear. And then about 10 years ago, it starts to expand further vertically by going from being a predominantly male, nearly all male, to getting into the female population. And it's done that by introducing a new concept, again, no scientific evidence, of masking. So the idea of masking is that you have the symptoms, but you've become so good at hiding them that nobody sees them. So you don't have to have the symptoms anymore. You just have to feel you have the symptoms. And what starts to happen is it starts to focus on if you like, the majority psychiatric population amongst adults tends to be women. Women with senses of not fitting in, of anxiety, of a fragile sense of self, of insecurity. So instead of asking why we seem to have more women presenting in that way and what that means about our culture, about our society, about the pressures that people are being put under, If you turn it internally, there's a lot of money to be made. So once you expand it that way, because the symptoms are so non-specific, the so-called symptoms, and once you've introduced the concept of masking, you don't even need to have so-called symptoms anymore. You just need to feel them in some way. And because it's also connected with the prescription of stimulants, which are, the majority of which are amphetamine based, people take amphetamines because they have quite an instant impact. So people feel differently when they take them. But there is a good reason why we warn people about amphetamines, because they raise our life functions, our metabolism. So you're going to be more likely to experience an increase in your blood pressure, a difficulty with sleeping, a decrease in your appetite. And over time, these are potentially very dangerous to us, as well as the fact that these are very addictive substances. So you've got the same problems again. You're going to develop tolerance to it, like you do with any substance that's potentially addictive. So it will decrease in its effectiveness over time, but you may be more likely now to turn to accessing these medications, but they come in street drugs. So you start opening a whole Pandora's box. There's good reasons why medicine for most of its time has stayed away from amphetamines. It's flirted with amphetamines in the history of medicine for quite a long time. And it comes in, and then we realize, oh dear, this has a lot of serious long-term side effects. So it comes in and goes out, and comes in and goes out, and it's coming big time again now.
Wow.
And so the way, so that is thing about mental disorder, and if I can just say briefly about what diagnosis is, to kind of complete that picture, so that hopefully people can understand why ADHD is not a diagnosis. So a diagnosis is a system of classification based on an understanding of proximal cause. In other words, the initial cause of whatever it is you're classifying. So you take your car to a mechanic to run diagnostic tests because it keeps cutting out. Or you take your computer to the IT technician to run diagnostic tests, and that's what they call them, to look at why your program isn't working. It should. And in medicine, we understand diagnosis as something that refers to a proximal cause. So there's a particular technical skill in terms of understanding. This is why, for example, a condition like diabetes is not defined by describing the symptoms. So you don't define diabetes as, being thirsty, going to the toilet a lot, fatigue, because number one, diabetes might not present like that. It actually might not present with any symptoms, but it might present with just recurrent infections, but also plenty of other presentations might present like that. And sometimes I think with this culture of carries a water bottle with them and drinks all the time, I've seen young people concerned that they have diabetes because they go around drinking all the time, and then of course they need to go to the toilet, and then they look it up on Google and say, "Oh my God, I'm thirsty all the time, and I go to time, maybe I've got diabetes." So those symptoms can be just a functional result and has nothing to. So you don't define diabetes by describing the symptoms that are often associated with it. Diabetes is defined using criteria related to blood sugar that is consistently considered too high. You have an empirical anchor. You have something external to the subjectivity in which to anchor a case. So once you have an empirical anchor to create what you might call caseness, you have a starting point to build a body of technical knowledge, because you have a good idea now that you're comparing like with like. So you can look at secondary causes, you can look at impacts. Now, there's a huge amount of problems and discussions and debates. Where do we put the boundary? Do we have a concept of pre-diabetes? Where do we put the boundary for a sugar level that we consider to be merits a diagnosis? When should we look at purely dietary approaches? When should we include medication? etc., etc. So you don't eliminate these various debates, important debates, but you have an important factor of empirical anchor. Do you follow me?
Absolutely.
Now, compare that with the diagnosis of ADHD. And we think of ADHD as a diagnosis, and that's how we treat it. We treat it, we say, oh, my child is hyperactive and has trouble concentrating because they have ADHD. That's what we imply that this has a causal relationship. But all that ADHD is a set of behaviors and people filling in forms, questionnaires, where they have to tick, this behavior happens rarely, sometimes, often, very subjective. And if you look at every behavior, they are subjective. So take a familiar one that often makes me laugh. Often squirms in their seat. It's actually listed as a symptom.
Wow.
So what is often? What is a unit of squirm? How would I measure a unit of squirm? Is there any difference by age? So there are all of these things. And if you take every behavior, it often starts with the word often. Usually always starts with the word often, and it's subjective throughout. So you have no empirical anchor. But what it means is the definitions of what we call diagnosis in most of psychiatry, not all of psychiatry, but most of psychiatry, is descriptive. It doesn't refer to a proximal cause. It describes, it's a set of descriptions, and they're very subjective descriptions. And the problem with treating it as a diagnosis is you get caught in a circular thinking trap. So you can illustrate that by saying, what's the reason, for example, if I had a diagnosis of ADHD, what's the reason I can't concentrate and lose things all the time and I have a poor memory? The doctor might tell me, well, the reason is because you have ADHD. And I would say, how do you know that's the cause of me having poor concentration and losing things and not remembering where I put stuff? And the doctor would say, I know you have, it's caused by ADHD because you have poor concentration, losing things, and you can't remember. So a description cannot cause itself. So we're treating something in a circular thinking trap. Because you don't have an empirical anchor, description is being used to say that it causes itself. This is a bit like going to the doctor and saying, doctor, I've got this terrible pain in my head. What's the cause of that? And the doctor says, well, it's caused by a headache. That is the equivalent. Honestly, a description cannot cause itself.
So true.
Now, there are many problems in the practice of medicine, not just in psychiatry, where we have an absence of empirical anchors and where we struggle, where we don't really know. So there are quite a few so-called diagnoses that exist outside of psychiatry where we have the similar problems. For me, psychiatry, because of the allure of the idea that we've got diagnosis and we've got technical fixes, we've got things upside down, because we could help the rest of medicine deal with this issue of subjectivity. Because once you're in the realm of subjectivity, the whole psychosocial dimension becomes a big part of trying to understand what might be helpful or what might be going on for particular patients. So you actually often find the patients who start collecting these psychiatric diagnoses also start collecting some of these other physical diagnoses or apparent physical diagnoses for which there isn't an empirical anchor to. And we could be helping the rest of medicine with that, because that problem sort of crystallizes itself in psychiatry. But the bottom line is ADHD is not a diagnosis. It does not refer to a proximal cause. And to treat it as a diagnosis is, in my mind, very dangerous, because you're in a circular thinking trap and you're going to be expanding this way and that way. And so I now think that the popular psychiatric diagnoses that have spread, they're not diagnoses, they're actually commercial brands. They're actually marketable commercial brands in which a market of assessments, people charge a lot for an assessment,
Wow.
experts, drug
Coach.
industry,
Yeah.
therapy, coaching, books, courses, research. So these are not diagnoses, they are commercial brands, and they operate in the same way as most consumer brands. They offer you something as if they say, if you get this, your life is going to be better. And like most commercial brands, sooner or later, they're not as effective as they were,
Mm.
but now you're hooked into it. So now they can sell you something else. Oh, yeah, but now you need this on top of that. Now you need to go to this course. Oh, maybe you also have autism. So now you need to go and get a assessment for autism. And then, oh, maybe you also have bipolar disorder. And I've seen this even in kids. They're starting to collect diagnoses.
Wow. What you've just said is just incredible because literally I'm just watching my patients
Yeah.
on this journey. And it's
Yeah.
just incredible how they almost come to a self-diagnosis and then
Yeah.
seek a specialist to confirm it. But what would the specialist know in 15 minutes about your life that you've just created you've ticked a screening questionnaire?
That's all they know.
Yeah.
If that's the way you're going to approach it, then that's all they know.
Absolutely. And they often leave 15 minutes later with a script. You're absolutely right. It's one of the ADHD stimulant medication. And I loved how you explain the side effects, reduces your appetite. But what about the withdrawal symptoms? When I was reading about the withdrawal symptoms, when you come off, you can get manic and depressive as well.
Yeah.
And as a
Yeah.
result, I see this trend and it's just an eye opener now. Here's an antidepressant to go on top.
And the next thing you'll get is mood stabilizer a bit later.
Wow. And then you're absolutely right. I've seen it in my patients where one is just not working as much. Now let's switch to another. And it goes on and on and on. And I can't remember the name of the lady that did a 30-year study on stimulant medications, Ritalin. And this study's almost like squashed, but over 30 years, she realized that what was discovered that those who were taking Ritalin were more likely to engage in addictive behaviors, end up in jail,
Smoking and cocaine was the two big ones, yes. Nadine, and I've forgotten her second
Lambert,
name.
is it Nadine Lambert?
Yeah, Lambert. Yeah,
Yeah,
Nadine Lambert. Yeah.
absolutely. And
She followed up over 500 people. So
yeah, and now I'm really educating
yeah.
parents who think this is going to be a quick fix for their child, or I think they often think they're doing the best for their child.
Oh,
And
of course. This is what's been advertised. As I say, this is a brand. It's been advertised as having these kind of miracle aspects to it and being underdiagnosed. And, this is what doing the best for your children. There's a large study in Australia, actually, that took place. I think Kasdin was maybe the lead author. It was published a couple of years ago, where as part of a longitudinal study because there's a number of these longitudinal studies going on in a lot of countries nowadays where they have a group of kids and they follow them up every 2 years, every whatever, and they do a battery of tests and interviews and so on. So they had about 400 kids who they could compare a group of kids based on their questionnaires around their behavior who got a diagnosis of ADHD compared to a group of kids who had a similar ratings on behavioral questionnaires, but didn't get a diagnosis of ADHD. And they followed them up for about 7 years until they were 14, 15 years of age. And those who got a diagnosis were doing worse on several, including things like self-efficacy, peer relationships, perceptions of how they were doing, all these sorts of things. Labeling has consequences, particularly for kids. You impose an idea of something fixed and internal to them, as opposed to being open to the fact that children are always changing. And interestingly, there's also a similar study from Ireland, again, as part of longitudinal, same thing. Kids who got the ADHD diagnosis ended up doing worse 5 years later than the kids who had similar behavioral presentations who didn't. So, there's a lot of evidence out there that this kind of process of labeling and possibly the treatments directly itself doesn't lead to improved outcomes. It might well lead to the opposite. And there is the longitudinal studies from some people who are interested in this will have heard about the multimodal treatment of ADHD, a study that was started in the mid-90s. Originally, the 14-month publication after 14 months of the study suggested that children on medication do better than children not. But then they followed the group up and they published results at 3 years, 6 years, and they've even followed them up to 8. I think recently they had a 16-year follow-up study. And over time, that picture changes. The group who are on medication start lagging behind. The group who never had medication tend to have either equivalent outcomes or slightly better outcomes. So in a number of parameters. And there's another study from Australia called the RAIN study.
Oh, right. I think I've heard of it, but yeah.
Yeah, which again found the group who didn't have medication. So this was, again, a naturalistic study looking at the group who did have medication and the group who didn't. And the group who did have medication were doing worse on a number of outcomes. The most worrying one for me was so this was an average 7-year follow-up. Children were in their late teens. The children who'd been taking medication had on average something like a 5 millimeter Hg higher blood pressure. Again, because we know it affects these life function systems. So, for kids at that age already, they're taking things that are going to lead to a high blood pressure. That's not good. That's not good.
Do you want to move on to, and I think it's so important. So when a child comes up, actually the parents bringing a child to you saying, I think my child has ADHD, what kind of conversations do you have? What do you look at?
I find that if you can get the conversation beyond this idea of that we're going to categorize them in a particular way, these questions often become secondary and quite often disappears. So, for example, one of the things I like to do is a lot of what you might call Socratic questioning, because I'm trying to understand what difference something is going to make. So I say, okay, let's imagine that we go through assessment, and at the end of the assessment, I've diagnosed your child with ADHD. What difference do you think it's going to make to your life? Well, I'll understand them better. Okay, so if you understand them better, what difference do you think they might make? Okay, they might have a treatment that you can give us. Okay, so let's suppose there's a treatment I can give you. And I'm trying to get them to start visualizing what difference is it that they want to see, because I want to transfer this idea from a fictional, abstract idea to concretely in their material life. What is it that they're looking? Is it something to do with how they're doing at school? So what sort of help and support are they having at school? What is is it something to do with their behavior at home? Or what aspects of their behavior at home are they trying to change? What is it? So we might end up talking about what happens at home. And so they say, I ask him to get out of the bed in the morning, he won't get out of the bed. Okay, so what do you do when that happens? What's the interaction? And one of the concepts I use is the idea that some children are more intense than others. And the point about this is to move it from an idea of something that goes on internally in the kid to an interactional concept. And I say some kids are more intense. And what these intense kids tend to bring out is stronger reactions in the people around them. So I talk a lot about emotions. And I say emotions are a form of energy. The higher your emotion level, the stronger in relationship your sense of connection is. So when you're in love with someone, you can't get them out of your mind. When you're angry with someone, you can't get them out of your mind. It's a form of connection. It's an energy of connection. And I use the metaphor of dance. Each relationship has a particular dance in how connection happens. So these kids who are very intense are often very connected. So I could talk about how does that affect you as the parent? because what often happens, my other concept, if you like, analogy, is that emotions are viral. You catch the emotions of the person you're closest to. So if the child is getting frustrated with you, you start getting frustrated back with them, they get frustrated with you, and the level of emotion just keeps going up and up. So it might lead to an opening to talk about that in more relational terms. And then that might lead to an opening to talk about how we might bring down the intensity of the emotion for all of you, or how you might be able to develop connections around other things. Because what I find happens quite a lot these days, because we've advertised the idea that childhood is so full of risks, we've made what I call the ordinary, understandable struggles of growing up, the ordinary, understandable battles and disagreements and frustrations that parents have. We've turned them into potential sites of something going wrong that needs an expert to sort out. And I think we've created a culture where we're all trying too hard with our kids. A lot of the time, I'm trying to convince parents, you don't need to try so hard. The harder you try, the more emotion is flowing of the sort that you don't want to flow. And you keep accidentally reinforcing a sort of dance that you do. As I say, I use the metaphor of dance between you and your child. And I see that as a lot more important than thinking about how to control behavior, thinking about the emotional dance.
Wow, I
So
love
that's just a few things. That's just a few little
I loved what you
pointers.
mentioned. Actually makes me think about a family that I'm, looking after and how I notice the dad is not as emotionally connected to the son. And when I see them all together, yes, the son acts up, he's sensitive, he's emotional. But on one occasion, I saw the son just with the mum and no dad around, how absolutely emotionally regulated he was. So that kind of makes me think what's going on in terms of that connection he has with his dad and whether that's playing up in his life. And yes, he has been diagnosed with ADHD.
Of course, of course he has.
Wow.
So even those who are diagnosed with ADHD and autism, and sadly, there's plenty of places you can get diagnosed with ADHD and autism. You can still have those questions without needing to challenge the diagnosis. You're just trying to open out the conversation. The problem with this idea that you've got a diagnosis is the concept of treatment then revolves around the idea of reducing what is being classified as symptoms.
Mm.
And that leaves you down the pathway of behavioral control and all sorts of things.
Yeah.
Or when there are problems, maybe we need to up the medication, and actually avoids looking at any of these things that might actually, in the long term, be more impactful, more helpful for them as a family.
Yeah, I would love to know your opinion, Dr. Sami, about the impact of screen time and children's behavior. And I was recently on holiday with my husband, and I just looked around at breakfast. And
They're all on
actually,
phones. Parents too.
yes, I was horrified that amazing families were on holiday together. Every single person around the table was on their own phone, children and families, and it was just like the similar in every part of that restaurant. And I was like, oh my God, is this what's actually affecting connection and emotional regulation? And is that contributing to these behavioral issues?
Well, it's bound to have an impact, isn't it? I mean, you've just described a situation which normally would be a meeting point for a family is everybody's in their own little world. So this is the kind of hyper individualism that our society is promoting. I do think we also have to be careful not to ascribe too much to the role of social media. Of course, it has an impact. But one of the things that I see, or one of the things that I think, is that it accelerates concepts that actually, sadly, people like those in my profession have already introduced. So it can turbocharge concepts that are not helpful for us as a culture, like ADHD. So that gets turbocharged. And it can also accelerate patterns that were already in existence. So we've already live in an individualized society. We already live in a very marketized culture. which is so, for the various social media companies, they thrive on getting people to click. That is their marketing model, but marketing is already there. I see it as an accelerant of trends that were already there rather than the cause. And of course, they contribute in that way.
Yeah. And finally, I do want to mention the impact of like nutrition and even sleep. And I just want to mention a story where a mom booked an appointment for her son who's only 7 and said the teacher's thinking, yep, he's going down that route like his sister who's got ADHD. He's absolutely fine at home though. He plays basketball, he swims. But the teacher just noticed he's just not focusing. And I had this great conversation, such a lovely child. And I go, let's just do some bloods and just be sure, because as an integrative doctor, we always want to go root cause and find out. And I really wanted to share this story to as many listeners, because it turned out his ferritin was 2, and it turned out, which is iron, and he is now diagnosed with celiac. And he's
weird. I had a case like that some years ago as well, where there was a concern about, and I just noticed he was very thin. I just did a battery of after the battery, and it turned out he was celiac. Yeah. And I've also come across children who were asthmatic, and these are conditions that cause irritation in the body, isn't it? So, and he was under treatment, but he obviously didn't know how to use his inhalers properly. He wasn't. So there are important reasons why medical doctors should also be included in these, because there are these conditions that might act as irritants. And of course, if you've got something that's irritating your body, you won't concentrate as well, would you?
Absolutely. Thank you so much for your time, Dr. Sami. What you've said is just so impactful, so important. I want to get this message across to as many, many listeners. If you had a final few words, what message do you want to get across to as many people?
Beware the consequences in the medium and long term from the allure of these new marketable brands that are being sold to you and to potentially your children. They might seem like they offer all these great things, but in the long term, the evidence is the opposite. They expose you and your children to more potential harms than benefits. So just beware.
Amazing. Thank you so much, Dr. Sami. And I will include all the links to where people can find you, your books, in the show notes as well.
Thank you.
Thanks for listening to 6 Hats, where it's all about progress, not perfection. If this episode spoke to you, don't wait, hit follow now, leave a quick review, and share it with someone who needs to hear it. Want to take your next step today? Download my ebook. The link is waiting in the show notes. And remember, this is general advice only. Always speak to your practitioner for anything medical. See you next time.